Hello, everyone, and thank you for listening today. My name is Adriana Bearse, and I am a program manager in the Research and Health Promotion Department at San Ysidro Health, a federally qualified health center serving a primarily low-income Latino population through a network of clinic sites in southern San Diego near the Mexico border. Today I'm going to talk about an academic community partnership between our health center and researchers at two local universities, Dr. Samir Gupta from the University of California, San Diego, and Dr. Sheila Castañeda of San Diego State University, on a couple of community-based research studies testing strategies to promote colorectal cancer screening amongst vulnerable Latino patients we serve. I'll describe some of the strategies we've used to overcome barriers to screening and provide some preliminary results to date. As you may be aware, colorectal cancer is the second leading cause of cancer-related death in the U.S. Screening for colorectal cancer can reduce incidence and mortality. However, participation rates remain lower amongst populations such as low-income Latinos, the uninsured, and those born outside the U.S. There are a lot of disparities to be addressed for underserved populations served at community health centers such as ours. There are also many barriers that contribute to lower colorectal cancer screening rates amongst Latino populations in particular, including lack of awareness or knowledge about colorectal cancer, language or literacy barriers, lack of insurance coverage, fear or denial, and other needs or life circumstances that are more pressing than preventative care. Overall, there is a need for more standardized educational and screening programs for this population in order to support timely screening. To overcome some of these barriers, there are in fact a variety of evidence-based strategies clinics can make use of, including outreach approaches such as mailings or client reminders, in-reach approaches such as health education for those frequently attending clinics, or more structural or provider-based approaches such as implementing pop-up reminders in the electronic health record. However, as I'm sure you all know, what works best for each clinic varies, and so we wanted to see what would work best for our clinic setting. We already do a lot of work with lay community health workers and health educators in our department, so we were particularly interested in testing in-reach and outreach approaches that would remove the burden placed on providers and help increase screening rates. There is also some evidence of the effectiveness of these approaches in increasing screening for Latinos, but not necessarily in FQHC environments such as ours. As a little bit more about our health center, San Ysidro Health, we are a federally qualified health center established in 1969 as a safety net clinic in the southern San Diego region. We currently have a dozen primary care centers along with a variety of other services including dental, mental health, and WIC, and we serve over 90,000 patients. The majority are Latino, living below the federal poverty level, and many are uninsured. We also have a research and health promotion department, that's the department that I belong to, that already provides clinic and community-based health education services. And so we wanted to capitalize on this organizational capacity. We also know that increasing colorectal cancer screening is aligned with HEDIS measures and with clinic-level priorities. So we were able to capitalize on research collaborations with SDSU and UCSD to obtain funding for a pilot study testing the feasibility of implementing in-reach and outreach strategies at our clinic sites amongst patients not up to date with screening. We made this happen with funding from multiple sources and had organizational buy-in for learning more about what would work in our clinics to increase screening rates. As a brief overview of the pilot study, we tested two different strategies, each with 100 patients. The in-reach strategy involved patient navigators, basically lay community health workers, providing 15 minutes of health education on the importance of colorectal cancer screening to participants during primary care visits and giving them a fit test. The outreach strategy involved mailing educational information and fit kits to participants for them to send back. Both strategies also involve telephone reminders and referrals for additional screening or treatment as needed. Eligible participants were Latinos aged 50 to 75, not up to date with screening, excluding those with a history of colorectal cancer or inflammatory bowel disease. We recruited participants through an electronic medical record data query for eligible individuals, and then either the patient navigator would approach the potential participants in the waiting room on the day of their clinic visit for the in-reach strategy, or for the outreach strategy, they'd get educational materials mailed to them. Participant demographics are shown here for the pilot study. Of note, participants were not randomized and we did not oversample for different groups, so the proportion of insured and women ended up being higher in the in-reach group. These were the participants more likely to be coming into the clinics. So what were the outcomes of this pilot? Overall, we saw some preliminary effectiveness of the strategies being tested. InReach showed a 76% increase in FIT screening at 3-month follow-up, and the outreach strategy showed a 19% increase. This is all comparable to previous studies testing these approaches in Latino samples, and it was very exciting to see that this could be effective in our clinic setting with our patients. And so the next step was to scale this up, and we were able to do this with a randomized controlled trial that we received funding for with our same collaborators at the 2 universities. This RCT was informed by the results of the pilot, as well as some focus groups we conducted with 31 participants to inform modifications to our educational materials used in the intervention. We started this trial in September 2016 with 648 patients not up to date with screening, again identified through electronic medical record queries, and this time randomized to similar outreach, inreach, combined outreach and inreach, or usual care, which is basically opportunistic care provided by their primary care provider. We also conducted a medical record chart review at 6 months follow-up. Of note, this is a fully powered study currently in progress, and one of our challenges and ultimate successes was our ability to recruit Hispanic males into the study. This was a major challenge that we experienced, consistent with literature that males are less likely to come in to the doctor. We addressed this issue and were able to recruit more males into our study by adding more waves of data collection to focus on including only males, and were able to successfully achieve a high enrollment rate of almost 50% males and females for the final study. The intervention phase was completed in March 2018, and we are currently in the follow-up phase, which is ongoing with patients who were enrolled in the final waves of the randomization study. As of the latest review of the data, we have complete follow-up data available for the first few waves, and 6-month follow-up data will be available in the next couple of months for the remaining waves. As of now, we have not divided the analysis by intervention arm. However, we do know that our FIT completion rate is currently at 46%. Another success that we experienced with this study was successful use of REDCap, which is an electronic survey system across our institutions. This is something that has been very helpful from our clinic perspective in order to be able to increase our capacity to collect data in an easier and more streamlined way for future research studies such as this one. Overall, this pilot study and the ongoing randomized control trial demonstrate that evidence-based colorectal cancer screening strategies, specifically in-reach and outreach strategies, can be successfully implemented in federally qualified health center environments and have great potential to reduce disparities in screening rates amongst underserved Latino populations. These studies have been particularly helpful because they involve the use of patient navigators, thus removing some of the burden placed on providers regarding screening rates for their patients. We have also been fortunate to have clinic level, organizational level, and provider level buy-in for implementing these studies, and have benefited greatly from the opportunity to collaborate with institutions such as SDSU and UCSD to be able to test the effectiveness of these strategies in a systematic way. Moving forward, we look forward to hearing the full results of the randomized control trial study to be able to know more about whether in-reach, outreach, or the combined in-reach and outreach strategy is more effective in settings that serve our patient populations. I would also like to note that this project was made possible through a truly collaborative effort between our health center, SDSU, and UCSD. A list of a few of our key project staff across organizations is shown here, and we are very fortunate to be able to work on initiatives like this to improve the health of our patients. Funding sources for this project included the National Cancer Institute of the National Institutes of Health, the American Cancer Society, and the California Colorectal Cancer Coalition. I would also like to thank the California Primary Care Association and the American Cancer Society for making this webinar possible and providing an opportunity for information sharing and discussion across FQHCs regarding the important topic of how to increase colorectal cancer screening amongst vulnerable populations across our state. If you would like to talk further or have any questions, my contact information is provided here. Thank you very much.